access to the work that we do.
We cannot sit in this room.
All right, we are now live. Good morning, everyone. It is Thursday, January 8th, and it is Senate Health and Welfare. We've got a good meeting planned today, and I'll talk about that in just a minute. But before we get started, I think it's really important that we have a clerk in the committee to bring bills down to us and then to record votes and keep us online with getting our bills upstairs, helping folks get bills upstairs. So I would entertain a motion for clerk, guest Senator Cummings.
I would like to nominate our most experienced newbie, Senator John Morley.
How did I know?
All right, is there any, so Senator Morley, you've been nominated. Are you okay with that nomination?
Absolutely.
And are there any other nominations? Okay,
Any discussion? Do we have any discussion?
any discussion?
I just wanna, my name is hard to pronounce, so I just wanted to tell you, because you will have to do roll. Martine LaRock Gulick. Gulick, yeah, I know, I know.
I'm finally getting it.
It's been, yeah, it's been fun with Mr. Bloomer upstairs. But thanks, I'll second the nomination.
Okay, we're good then, and hearing no other nominations, then, why don't we just do this by, raising your hand and saying aye if you approve of the nomination and appointment of Senator Morley as clerk for Senate Health and Welfare.
I
Wonderful.
You gonna vote for yourself?
Sure.
Okay, all those opposed, and we are fine. Thank you
You're
for
welcome.
doing that.
You're
It is important to us,
Yep.
and it does require some attention when you get to doing our bills. Your experience, so yeah. And you can help our other new member, because he's filling his role, I think, in
Yeah.
institutions. It's great. Thank you. Okay, so this morning, just to help us through, you were interested in looking at historically where we are with the laws that we've passed on healthcare reform. So we've asked Jen Carvey to come in and give us a quick overview of some of those laws. And then the other issue that we've been concerned about is what is the effect of federal changes, that the big bill from July 1st. And so we've had to split up the testimony on those two things. So today we're getting a start on each one, starting with Jen Carvey on the laws we've passed and what's happening there. And then on federal funding, our healthcare advocate will be in today. Next week, we'll pick this up again. And tomorrow, actually, we're going to pick up federal funding from the Agency of Human Services. They'll give us the nitty gritty of the dollars and the people. And then next week, we'll have AHS in on the laws that we passed and the work that they're doing. So it was difficult to schedule this, and Callista's had quite a fun time doing it. But we will have the full testimony, first from Ledge Council, then from AHS on the laws, and then today from Mike Fisher, our healthcare advocate on federal funding, and tomorrow AHS on federal funding. So we'll try and get that background. I think it'll help all of us to do it, helps us back on our feet. So Jen,
Yes.
all right,
Is Mike in this meeting?
Like Marco?
No, Mike Fisher.
Yes, you can.
yeah, Mike came in and said hi. He's released. Oh, I keep forgetting to remind everyone to make sure your cell phone is muted. I got any trouble with this.
Good morning, Jen Carvey from the Office of Legislative Counsel, and I have not been in your committee yet this year, so welcome to the.
Oh my
new
gosh,
and
wait,
returning
before
new-
we start, I've met with you so much I forget, so. Jen, introduce yourself and then we're gonna have folks introduce themselves.
Okay, I'm Jen or Jennifer Carvey from the Office of Legislative Counsel. I was here when you were Representative Morley. So I've been here for a while. And I handle healthcare and human services issues. So you'll see Katie, and I don't know if they've met Katie yet.
I haven't met.
All right, Katie and I will both be here later this morning to talk about some important stuff. So you'll see a lot of Katie and me because we cover most of the topics that are in this committee.
So, and if you have a question about any of the bills, the specific language, Jen is the person to go to. I mean, you can start with me and others, but if you.
Right, I
Yeah.
probably do most of the healthcare bills.
Yeah.
Katie does most of the human services bills. So you'll see both of our names up there, but yes, we're happy to talk about any of the topics we work on or any, helping answer questions or understand what's going on.
Thank
Sure.
And so why don't you two introduce yourself?
John Morley of Orleans District.
Yeah, John Benson, I have Orange District.
Great. Well, welcome to you both.
Yeah, it's great. We're glad you're here. And you know the rest of us. Okay, so Jen,
All right.
welcome and go right
Yeah.
ahead.
Okay, so my understanding of what we're starting with this morning is looking at a couple of bills from recent years that are working on healthcare reform, specifically around what's being called the transformation efforts. So looking at a couple of provisions from, or summary, a couple of provisions from Act 167 of 2023, and then Act 60 or 2024. 2022, when was that? I guess 2022.
Yeah,
Oh,
I
we're-
wasn't here.
Okay, 2022. And then Act 68 from last year. We'll see what else we have time for. So, pull up. Melissa, can you make me a co-host so I can share? Yep. So I'm putting up, this is a document that I had put together for a health reform oversight committee meeting. We've looked at it a couple of times there. You can see it. You can see it. There we go. And so this is just looking at a couple of specific provisions from Act 167 of 2022. And then there was a piece added to it in 2023 as though it were in the original act. So section 1 from Act 167 was looking at the development of a proposal for a subsequent all-payer model agreement. This was to come after an agreement we had with the federal government, trying to get participation from all or most payers in a particular way of aligning payment processes. So this language required the Director of Healthcare Reform and the Agency of Human Services to work with the Green Mountain Care Board and develop a proposal for whatever was going to be next after that all-payer model agreement with the federal government. And that's how we can get Medicare's participation in our multi-payer alternative payment models. Yes.
Can you give a short definition of all payer model? What all payer means? Or alignment, what it means to align payment?
Yes, I mean, we have many different payers in this, in healthcare space. We have, and some of them we have some control over and some we don't. So Medicaid is a state federal kind of partnership. We have some authority there, but we need to get permission from the federal government to do a lot of stuff. Medicare is all federal. So unless the federal government specifically gives us permission to have Medicare do something a certain way, we have no authority as a state to require Medicare to pay for services, pay in a certain way, pay certain amounts. Then we have the private insurers. So for commercially insured plans, and if you have Nolan's pie chart from yesterday, whenever you talk to, that's great. So for the private insurers, for commercial fully insured plans, the state has significant amount of authority to tell them how to go about doing things, what to cover, how to pay, what to pay. There's also self-funded or self-insured plans, and if they are not government plans, then we are preempted under federal law. So we're not allowed to tell them what to do unless, again, the federal government were to tell them to do something in a certain way, which is some of how under the Affordable Care Act, we got a little bit more alignment with what's covered because the federal government pulled the self-funded plans, some things I had to do. But otherwise we can only ask them, but they don't have to agree to participate. So when we're talking about all payer model and all payer payment reforms, we're really talking about Medicaid, private insurance, and Medicare to the extent the federal government is willing to approve. And then anybody beyond that is largely voluntary. There are certain ways we've structured things going forward that may allow for some greater uniformity because we're controlling the provider side, not the payer side. Is that helpful?
Questions?
No, we got a lot of this yesterday.
Okay, good. Okay, this is great.
What's all,
Great, yes. It's a great one back. Grade 101.
Reinforcement's great.
Right, and when it all makes sense based on what you've already heard, that's helpful too. Building. Right.
that's.
Yes. I'm more like if you've got the basics and you've got the base level and then the next pieces make sense. That's a sign of progress. All right, so this act required that the state develop a proposal for a new way. The all payer model was a particular agreement with the federal government that was time limited. So kind of what's next in our multi-payer alternative payment models, and particularly around how to get Medicare participation. And there were certain things that the development of the proposal had to include, at least include consideration of, and that was looking at alternative payment and delivery system approaches. So not just how do we pay, but how is the care delivered and where for hospital services and community-based providers. So that was the part of that act that directed the Agency of Human Services to do things. Then it also directed the Green Mountain Care Board, in collaboration with the Agency of Human Services, so now Green Mountain Care Board is leading, to develop value-based payments, including global payments, from all payers, again, all payers to the extent we can, to Vermont hospitals or accountable care organizations, or both. Determine how best to incorporate value-based payments, so payments based on the value of the care, or the care setting, into the board's regulatory processes. Yes.
So when we say value-based care, we're talking about looking at the outcomes for the care.
Often, yes.
Yeah. Okay. I mean, it's broad.
Sometimes it has to do, I think, with the right care in the right place, at the right time.
I know what ACO is, the acronym, but what is an accountable care organization?
So accountable care organization, One Care was one, if you've heard of them, so they, One Care Vermont, so they wrapped up operations at the end of last year. But they are, it's an organization that contracts with providers to provide them a set amount of money to care for the population that they are caring for. And there are sort of arrangements between the two of them about attribution, which patients are attributed to the accountable care organization, which providers are participating in the accountable care organization. But it's kind of coordinating the care at a larger level than individual providers. Green Mountain Care Board regulates them. We are down to many fewer in the state than we had, and largely only in the Medicare space. But there have been there's arrangements with, at least with One Care, was arrangements with Medicaid and commercial insurance to participate. Trying to get it's a lot of it is around trying to kind of get our arms around or get some control over what costs are and what care is appropriate. All right, so the Green Mountain Care Board was supposed to develop value-based payments, determine how to incorporate those into the board's regulatory processes, recommend a methodology for determining the allowable rate of growth in hospital budgets. Green Mountain Care Board regulates hospital budgets, and consider the appropriate role of global budgets for Vermont hospitals. We will get a little more into global budgets in Act 68. We talked about this in healthcare the other day, but part of the issue with global budgets or global hospital budgets is the very initial step is defining what people mean by global hospital budgets, because people mean different things when they use that. All right, section 2 was hospital system transformation. This is a lot of what we are continuing to talk about today. Section 2 of Act 167 directed the board in collaboration with the Agency of Human Services to develop and conduct a data-informed, patient-focused, community-inclusive engagement process for Vermont hospitals. So kind of convene everybody and talk about and engage them in talking about Vermont hospitals and how we can reduce inefficiencies, lower costs, improve outcomes, population health outcomes, reduce health inequities, and increase access to essential services. And some of the outcome of this, if you remember hearing about the Oliver Wyman report, there was a lot of attention on that a year or 2 years ago. And some of the recommendations from there, I think, are starting to trickle through into some legislation.
Yes, sir.
Just a clarification. So is there regular meetings that occur between the different hospitals that meet on a regular basis to continue this effort, or how is that working?
A lot of this is being, and you'll see some of this in some of the other legislation we'll look at. A lot of this has kind of transitioned to the Agency of Human Services leading the transformation work with the hospitals. So yes, they are facilitating meetings, not necessarily all of the hospitals together all of the time, but in part because some of their needs, the hospital's needs are different and their community's needs are different. But yes, there's ongoing work and engagement with the hospitals, and also some work with the hospitals meeting together to discuss issues.
Yeah, and that's what we were talking about yesterday, where the hospitals have really taken some lead, strong leadership in evaluating what their needs are regionally and working with the AHS to make change and doing a lot of good work.
Okay, section 2A, which was actually, if you look up here, added by a 2023 act. So a little unusual, but in this case, we opened up an old act and put in a section. And this section directed the Agency of Human Services to start doing the transformation planning, engage in transformation planning with up to 4 hospitals, to be informed by that data analysis and community engagement effort that the board was doing in collaboration with the agency, and provide a progress update to legislative committees in February of 2024. In this act, in this 2022 act, there was $5 million appropriated for this work, $900,000 to the Agency of Human Services in fiscal year 2023 for that work on the subsequent all-payer model and hospital transformation efforts, including hiring consultants, and a little over $4 million to the Green Mountain Care Board for its role in those 2 processes as well. There were a number of deliverables that were required and that were provided. The act required the Agency of Human Services to report on its all-payer model subsequent proposal activities, and the Green Mountain Care Board on its efforts, including around hospital community engagement, by January 15th of 2023. And so I've linked to the agency's 2023 presentation and a 2024 update. A couple of reports from the Green Mountain Care Board in 2023, 2024, and a couple of presentations from them. There was also a requirement for the Agency of Human Services to provide an update on its stakeholder engagement in March of 2023, which it did. And the Green Mountain Care Board, and that's that Oliver Wyman report, produced a community engagement report. I'll link to that. So that's the Act 167 that you hear people talk about a fair amount. There's a lot more in Act 167 on other topics, but these are the specific pieces in this area. And then I was going to jump over to Act 68.
Just want to take a breath and see if there are questions or clarification. And we have that summary sheet on our webpage.
I believe so.
Yeah, so
Just checking. Indeed.
back and look, and the
Excellent.
links are live, I think. So
I hope so.
yeah. Calista, they're out.
Yes, they are.
Good, she's got it.
Yes.
So if you have questions about it now or later, we can come back and if you want to come back to this and drag Jen in again and talk about it.
You'll see me lots anyway.
I know.
Ask me questions.
It's good. Or you can meet her separately.
That's true. All right, so do you want to do Act 68? And I brought my whole presentation that I put upstairs on.
That would be great.
Acts,
That would be
but I
good.
don't know, so I was just gonna use the Act 68 slides from there, but I can do whatever you want on Acts from last year. Do you want to stick with Act 68 for the moment, since we're kind of on this?
Let's start with that and then we can move into the solvency or the other pieces that I don't know which ones you have. You have, which acts do you have?
There's so many,
Okay,
you know, many of the ones there.
okay, well, let's start with that one, Renal.
All right. All right, so we have Act 68, which was healthcare payment and delivery system reform. It was S-126, it's when we were here in the building, so I think people are still learning the new Act number, but that's what Act 68 is. Oops. So the first big thing that it did, and I think you'll be hearing a lot more about this topic this year, was to require the Green Mountain Care Board to establish reference-based prices that represent the maximum amounts that Vermont hospitals can accept as payment in full for items or services delivered in Vermont. So let's break this down a little bit. A reference-based price is a price that is literally linked to a particular reference. In this case, the reference would be Medicare, the Medicare rate for that item or service, or another benchmark as appropriate. Some are not included in Medicare, some may not be a rate that makes sense for Vermont. But the idea here would be to be a percentage of Medicare rate. So it might be 125% of the Medicare rate. It might be 300% of the Medicare rate. It might be less than 100%, although probably not in many circumstances. But the idea here is just to have some kind of agreed upon reference that we can use for the Green Mountain Care Board to set rates, to set prices that will be what the hospitals will get paid for items and services. So they might not be the same for all Vermont hospitals, depending on their financial needs, their payer mix, et cetera. But that is the concept, to start getting cost containment by setting prices.
When I get a bill from say North Country Hospital, and then the bill comes through, it's usually like, we'll just hypothetically say $3,000, but the bill is actually $1,000.
Right.
I don't understand for the life of me. I don't want to, because Blue Cross Blue Shield says we'll pay this.
Right.
And that's payment in full, although the bill was $3,000.
Right. So the way, and there are probably other people who are better at explaining this than I am, but the way in general hospital prices work now is the hospitals have, I believe what this called a charge master, which is like a comprehensive list of all of their prices, but their prices aren't necessarily the price that any individual person or insurer pays. It's kind of the basis for the negotiated price. So they might set,
Why do they even have it on there? Then it's a negotiated price.
That's a good question for the hospitals.
Yes,
Yeah.
And for the regulatory body,
right.
Yeah.
So
which is why we have reference-based pricing.
right, exactly. Right. It really is, I think, a lot of the basis for having reference-based pricing, so that you're not looking at, so that there is some general understanding. You can compare kind of the apples to apples of what each hospital charges for a service, what they're, and that's what they'd be getting paid essentially. And some transparency around what the pricing is and whether it's appropriate for each individual item or service.
Taking
Yes. And yes, there are others who can tell you more about the whys of how hospital prices came to be.
I'm sure I'll hear about it.
But yes, but they are, generally not what, they're just a starting point. And it might be, you know, an insurer might do a percentage of that price, which is generally less than 100%. Here, we're talking about potentially doing more than 100% for Medicare.
Just a clarification
Yeah.
on John's comment, and it says the reference base will be in place by 2027. My assumption correct that that should end what he's talking about, because now there is an actual base reference which.
So reference-based pricing, the words here are intentional, will start as soon as practicable, but not later than hospital fiscal year 2027. Doesn't mean they will all be set and in place by that point, but at least they will be starting. So they may not be in place for all services at all hospitals. Hospital fiscal year 2027 starts in October of this year. So the Green Mountain Care Board will be coming in, I think, next week or so to tell you how it's going with getting this set up. They did hire a couple of folks to focus directly on this issue, but it's fairly novel, I think, particularly to do on a statewide basis. So there is some limited reference-based pricing happening in public employee programs in some other states, but this is significantly broader and with the potential for a lot more variability among the hospitals, as opposed to some of those other states where they may set 185% Medicare is what they, is what will be paid for all services at all hospitals. Vermont is taking a more nuanced approach than that. So yes, I mean, theoretically,
Should
that-
end.
yes, it could end all of it, yes, and that very low.
Thank you.
Yep. So the Green Mountain Care Board is the one who will be setting these reference-based prices. They will then review the reference-based prices for each hospital annually as part of the budget review process. So check in and make sure that the prices that they have set continue to make sense and make adjustments as appropriate. Balance billing is not permitted with this. So if this is set up as the maximum amounts that hospitals can accept as payment in full. So that's it. That's the maximum amount. They can't take the $1,000 from the insurer and then bill you for another $2,000. That would be balance billing the patient or the insurer for something in excess of the reference-based price. The reference-based price is the top, the cap. And the act directs the Green Mountain Care Board with the Department of Financial Regulation to monitor implementation. The goal here being that decreased payments to hospitals should result in some decreases in health insurance premiums. It's not going to be 1-to-1, but there should be some downward motion. So there's specific directive for them to look at how that is playing out. The Green Mountain Care Board also regulates health insurance premiums for the major medical plans, so the individual, small group, and large group plans. The act also allows the Green Mountain Care Board, but does not require the Green Mountain Care Board, in consultation with the Agency of Human Services and providers and others, to set reference-based prices for services delivered outside a hospital, like primary care services. Some of the conversation around this last year was about potentially setting higher reimbursement rates for primary care services in an effort to shift some of the care that should be done in the primary care setting out of hospitals and into the communities. And it did specify that and as we've been discussing, the board's reference-based pricing authority does not apply to Medicare because we can't set prices for Medicare, and it would not apply to Medicaid either because there's a separate process that the Department of Vermont Health Access is already doing around setting. They set all the prices as it is.
We heard yesterday, one of the discussions about EMS services being able to provide additional care without transport, which right now they would not actually get reimbursed for those services if they don't transport. So I'm just curious if that is allowed. How does that fit in here? And is the board looking at that? Or could that be sort of whatever that's EMS service decides to charge?
So I think that's there's potential in the future that it could become part of this. I think there's a few pieces on the treatment without transport. I think the particular issue around that has been with Medicaid, and there was some directive last year, 2 years ago, getting them all confused, to require some Medicaid reimbursement for treatment without transport. I'm not sure what the private insurers do. I think there's already some requirements in statute for insurance to pay for services of emergency medical services. But it's possible, in setting rates going forward, it's possible that that could be part of rate setting, but I don't, because they're not hospitals. They're community or private community owned entities providing services. They're not part of this first rollout. All right, so that was reference-based pricing. As I said, I think you're going to hear a lot about that. It's a big initiative the state is working on. The act also required the Green Mountain Care Board to establish global hospital budgets if resources to do so are available. So you'll have to hear from the board about whether they have been able to start on that. Because there was no additional funding added to the bill.
No,
But that piece, then they would need staff to.
When did we first start the request for global budgeting? This isn't the first time that's happening.
Talking about, there's references to global budgets and global payments in the Green Mountain Care Board rate setting statutes from
A long time ago. Yeah.
2013.
Yeah.
But they've had the authority. They have never
Right,
been
they've never done it.
required, right? They've never done it. They've
Turned it
never been
on.
required
Yeah.
to do it.
Yeah.
I think they will tell you they would need resources.
Yeah, so there's a lot of discussion here about what works in terms of net patient revenue or total cost of care and all of those things that sort of fall into place when you start talking about budgeting for hospitals. It's more complicated than that. That's not so.
So it requires the board to establish budgets if resources are available for one or more non-critical access hospitals. So that's certain federal hospital designations by hospital fiscal year 2027. So again, that's the one that starts this coming October. And for all hospitals by hospital fiscal year 2030. So you'll want to hear from the board about where they are with any development in that area. The act requires a hospital that proposes to reduce or eliminate any services to comply with its hospital budget order to provide notice of intent to the Green Mountain Care Board, the Agency of Human Services, the Office of the Healthcare Advocate, that's Fisher's Group, and legislators representing the hospital service area at least 45 days in advance. And it allows the board to modify the hospital's budget or take other action as needed to preserve access to necessary services. You can make your somewhere on this year. The act gives the Green Mountain Care Board the authority to oversee hospital networks that derive 50% or more of operating revenue from Vermont hospitals. They have not had specific authority over hospital networks. This is like the UVM Health Network, which I think is now just UVM Health, but a grouping of hospitals with a board overseeing it. And the board can recommend actions.
I ask one
Yes.
clarifier first. There are some networks that deal with hospitals outside of the state. So
Right.
what authority?
So we have no authority over something that is based out of state. We have authority over Vermont hospitals. We have authority over Vermont hospitals' participation in activities with other, with entities in other states, but we cannot tell, for example, Dartmouth Hitchcock what they can and can't do.
And a stupid question on my part. Hospitals are all hospitals basically nonprofits?
All Vermont hospitals are nonprofit, but that is not a guarantee for the country. All Vermont hospitals are nonprofit.
Okay. And it seems like we're trying to stem costs with more oversight to them, for them, I guess I should say. Okay. everyone's nodding, so that's good. So I'm kind of getting it.
Wait to me.
Okay.
All right, so the board, in addition to overseeing any hospital network that derives at least 50% of its operating revenue from Vermont hospitals, the board can recommend actions necessary to correct aspects of the network itself or its financial operations that are inconsistent with the principles for healthcare reform. These are sometimes referred to as the Act 48 principles from Act 48 of 2011. They're codified in statute. Or the statewide healthcare delivery strategic plan, which is something you'll see coming up that this act directed to be established. So once that is in place, that will be guiding a lot of the healthcare delivery for Vermont. Separately, there's a lot of bullets that sort of don't connect because this is just in the order that the bill itself was. The act requires payers and providers to provide an unredacted copy of an executed or proposed healthcare contract. So a proposed or executed contract between a payer and a provider to the Department of Financial Regulation or the Vermont Care Board on request. And I'll defer to Madam Chair. It's been her interest for a long time.
This is important. So you're talking about more regulation as a way to get forward, but really what it's doing, what we're trying to do here is to increase transparency of pricing, negotiations, because healthcare is so personal for folks and we need to know what the costs are, where we're going. One of the things that I had discovered a few sessions ago was that our insurers who, Blue Cross and Blue Shield is so critically important to the state. We're not trying to diminish the benefit of our insurance companies in any way, but as I said before, to increase transparency. But what we understand is that the insurers are negotiating with providers, whether it's a hospital or a clinic or an individual provider, about reimbursement and other conditions within the insurance contract. So apparently you could have a non-disclosure agreement within these things. You could have a very high reimbursement rate for some and an extremely low for others. And it's a way that insurance companies were using to balance the bottom line. And the effect was that some of the providers who are down here, their bottom line was going further and further away. So having some transparency at the level of regulation, which is the Department of Financial Regulation, and then the Green Mountain Care Board for evaluating rates, makes a whole lot of sense to me. And I was somewhat surprised actually that DFR didn't have a full, hadn't had a full look at the contracts nor the Green Mountain Care Board. And DFR has responded really beautifully with some guidelines and criteria for contracting and making sure that they're done equitably. And the board is now able to look at the contracts and make sure that what the insurance companies are doing is in sync with what works for the whole system. So that's my interpretation of it all, and I think it has proven to be fairly accurate. Was a great concern to me. So if you want to talk further about it, I should talk about it. So that one line in the bill, big story.
It's been an ongoing concern both here and in finance that regulates health insurance, that more and more primary care, but more and more services are becoming part of the hospital.
Yeah.
Independent primary care doctors, according to them, are paid significantly less than doctors that are affiliated
The hospital.
with the hospital. And there's really one hospital that's been buying up a large number of independent practices. And that ability to survive financially has been very difficult for them. And part of there was a global payment right to some groups, the primary care, I think, under the ACO that we had to, they were getting like a flat payment
They're getting it. Yeah, there was some
Yeah.
comprehensive payment
Yeah.
reform.
that we had to do, we had to take care of last year when the
State filled in for
Yeah.
a period of time, and yes, and one of the reports that you'll see called for in here and coming up on the list later is looking at whether there's some capabilities from the ACO that the student should take on, which may fit some of that methodology based on the payment itself.
Some of the hospitals control or own or run some of the primary care. So, yeah, that's what I was thinking. So,
I can't think of one independent primary care doc in this.
I can.
There may be
Our
one.
chairman, Maria.
We have independents, but they are far and few between. And, trying to think in your area. I think they are, but they're not.
There may be.
Same with Randolph, affiliated with Gifford, but some of them, I don't know if you have any independents.
I don't know. I
I don't
don't,
either. That would be interesting. That would be a homework.
you know,
Yes, and they may reach out to you after
Thank
this. And you may be able to ask Health First as well.
Right, we're gonna have
Susan
Susan
Risen,
Risen and we're gonna have, when we start talking more in depth about primary care, we'll have all these folks in who can answer all our
It's
questions.
the survival of independent.
Yeah,
I mean, you name it.
yeah,
Physical therapy.
yes, yes,
All of
exactly.
those. There seems to be significant difference in what they're paid and in what's charged. But prices get a whole lot higher when you start to work for the hospital.
Right, and there are also facility fees.
Yes.
so they have more bargaining power. The hospitals must have more bargaining power with Blue Cross Blue Shield or whoever the insurance provider is.
Around here, well, they're a teaching hospital. So every time I set foot in a UVMC, and that's also my local hospital. When I first started, there was a note on the desk, along with the doctor's charge, which sometimes also goes up. I get charged, or my insurance company does, a $200 facilities fee. And if I go in and do blood work and have an X-ray, walk across the hall, I pay a $200 facility fee both times. You're getting into something.
The payment piece gets dicey.
Really, we have an independent practice in Richmond. It's been in here.
Right, in Richmond, we have one in Williston, yeah,
This is Jules Ravens.
and they,
Jules is laughing there.
independents are,
He was on the picket line on his 100th birthday, in front of the post office.
all right. Well, so we'll get independent care. We know we need to get that data. And because it's part of the whole regionalization work that we hear about from AHS, improved care and the more geographically isolated parts of the state.
Right. Ready to go back up?
Yes,
All
ma'am.
right.
Stop.
And Mr. Redford. Okay, so here is the part I mentioned around the statewide healthcare delivery strategic plan. So Act 68 directs the Agency of Human Services in collaboration with a number of stakeholders to lead the development of that plan. It is due to you by January 15th of 2028. And then it will be updated every 3 years after that, with the first updated plan due slightly before it's been 3 years, so that you're in a cycle of getting it before the session starts. So they'll be coming in by December 1st, 2030, as opposed to waiting until early 2031. There were a number of committees created. The Act created the 18-member Healthcare Delivery Advisory Committee. You'll be hearing, I think, from the Agency of Human Services a bit in there when they come in and do some of their reporting on the activities of that committee. There's also a new 16-member Vermont Steering Committee for Comprehensive Primary Health Care. Just on primary care. The act directed the Agency of Human Services to collaborate with the existing Health Information Exchange Steering Committee to continue developing the Unified Health Data Space. And it specified some elements of the development process, including determining whether it makes sense to integrate clinical and claims data, and if so, how to do so in a way that protects proprietary information. Some of the nuances of this were worked out in conference committee. So integration of clinical and claims data, if it is to occur, cannot happen before January 1st of next year. And then only if a majority of the Health Information Exchange Steering Committee thinks it's appropriate. And there's a report to do by next week on integration of clinical and claims data, including recommendations about whether and how, and then annual updates on the development and implementation of the Unified Health Data Space would be due starting next January.
So what's the difference between clinical and claims data?
Claims data has to do with what's paid, what's billed and what's paid.
And so how is that determined? Is that is there insurance involved in that?
Yes. I mean, there's billing from the provider, there's payment from the payer.
And so any prior authorization that would say, no, you have to pay for it yourself.
I don't know that the claims is just about services that were actually delivered. So if there was prior authorization required, so if somebody self-pays, the claim, because the claims data that we have is through the all payer claims database, which again is now some payer claims database. There's a US Supreme Court case that said we can't require the self-insurers to report. So if there's claims, it's all from the
volunteer.
Yes, from the self-insurance, it's all voluntary. But otherwise, if somebody self-pays, they do not report to the all payer claims database.
And then clinical
data has to do more with the I think what the patient is presenting with, what the issues are, what treatments are ordered, what the treatment plan looks like.
Trying to understand what actually transpired as a result of the assessment.
All right, separate provision down at the bottom authorizes the Green Mountain Care Board and has existing subpoena authority. And this language authorizes the board to share any of the materials it receives pursuant to a subpoena with the Agency of Human Services or Department of Financial Regulation as appropriate to those entities of work. So it allows them to collaborate with others, even if material was received through subpoena. There were certain sections in the bill looking at kind of short-term pressures and directing the Agency of Human Services to facilitate healthcare providers' response to the urgent financial pressures facing the system and identify opportunities to increase efficiency, improve quality, reduce prescription drug spending, and increase access to essential services while reducing hospital spending by not less than 2.5% for hospital fiscal year 2026. That's the year we're in right now. And there was a report due from the Agency of Human Services on the proposed reductions it had approved as of July 1st, due on that date. They have submitted that report, and Katie and I are going to come in an hour and go over lots of reports. So you'll see these are monthly updates, take up many of the pages of the list of reports we're going to go over with you. Monthly reports due during hospital fiscal year 2026. So from October of 2025 through the end of September of 2026. I put the link here to the Agency of Human Services website, but they're also on the legislative website. The act also directed the Agency of Human Services to identify specific outcome measures for meeting health care system transformation goals. So I'm going to pause there for a moment. We looked at a little bit Act 167. We talked about some more about transformation work here. There was interest in having AHS identify how they would know if they had met what the goals should be and what the outcome measures should be for determining whether those goals have been met. So there were some goals listed in the legislation itself, but whether and how those have been met was is hard to tell if you haven't identified outcome measures to look at. And so that information was required to be reported monthly from both the goals itself and how we're doing in meeting them from August of 2025 through the end of this calendar year. And those are on the agency's, some of those are on the agency's website. Again, notes or links to those that have come in that we will look at 11. And the act appropriated $2 million to the agency for incentive grants to hospitals to encourage them to do some of that short-term transformational work. With a report due by December 1st of last year on how much had been obligated and dispersed as of November 15th. That report has come in as well. Separately, there was a requirement for the Department of Financial Regulation to provide a plan for preserving the sustainability of domestic health insurers in Vermont. That's really statute speak for Blue Cross Blue Shield of Vermont. If you were following the news last year, you may have heard about some issues with their solvency, some concerns about their continued presence. There's been significant work to right that ship, but also the department provided a plan for helping to preserve their sustainability going forward. That report came in November, and there was a report due and submitted from the Agency of Human Services on, this is what I was alluding to, opportunities to retain usable capabilities developed by or on behalf of an ACO and funded with public dollars. This is looking at some of the capabilities that particularly One Care Vermont had around payments to providers that may be worth trying to continue even after One Care has wrapped up its work, which it did at the end of 2025. Finally, I think this is the last slide on this, so I guess our timing will be good. The act requires the board to report on its implementation of this act by the middle of next month. So you'll probably be hearing even before the report some of those activities. It also requires the Green Mountain Care Board annual report. There's an existing annual report requiring a lot of stuff in it, and starting with the 2027 report, they must include updates on their reference-based pricing and global hospital budget work. The Act also has a new annual reporting requirement for the Agency of Human Services relating to the status of its development and implementation of the statewide healthcare delivery strategic plan and the activities of that new healthcare delivery advisory committee. The Act created 3 new positions at the Green Mountain Care Board, 2 focused on reference-based pricing, and 1 for operations, procurement, and contracting. It also appropriated $2.2 million to the Agency of Human Services for their transformational work and for the creation of the strategic plan and work on developing alternative payment models. And it appropriated $1,212,500 to the board for those new positions, its contracts, and some language that was in the Act that we didn't specifically talk about, requiring standardization of electronic hospital budget data submissions so that the board is more easily able to compare hospitals using the same terminology and same categories. So they're more able to make comparisons of expenditures across the board. Nolan provided fiscal notes or prepared fiscal notes for several acts from last year, including Act 68. So if you want to look at his fiscal note on Act 68, that's available. Yes, that's the money.
Just a note about the notes, fiscal notes. So when Nolan comes in and we have a bill, we start working on whatever it is. Prescription drug bill, primary care bill, a hospital something bill. We'll start talking about it and then we'll ask the question, golly, how much is this going to cost? We want to know that. Nolan, can you do a fiscal note? And he'll say, no, I'll do a fiscal note after you finish completing your bill. So we're caught between a rock and a hard place. But just a heads up on that.
Yes,
And I'm guilty of asking that question as much as
It's a logical question. Yeah, I understand what the implications are.
Yeah, sure. So it's a fine line. We walk and try to sort it out. I have questions for Jen. Go ahead.
Did you mention the hospital ombudsman or watchdog or whatever you want to call it?
different act.
That was a different act.
Yep.
Thank you.
Also in here,
confused.
Yes, happy to.
Maybe mention
We have a
what
couple
those-
minutes if you want me to.
Yeah,
Well,
just mention what those other.
Yes.
things-
And I
Because that was
wondered-
probably one of the biggest things we.
Yeah, I know.
So there
I
were two,
think
so there were,
that's
I think, I would say that and the capping of the outpatient administered drugs is
Right,
a, is a
yes.
big piece of.
But I was also wondering, because I think Senator Morley had a really good question about the fact that the hospitals are nonprofit. In an environment that's for profit, and I think it would be interesting to talk a little bit about how, yes, they are nonprofit, but they can amass monies in reserves. And that was something that came up a lot last year. How much is appropriate? How much is
As far
too
as days
much?
cash on hand.
Yeah.
I think that would be a good question for the Green Mountain Care Board,
Okay,
because they are in the lead on hospital budgets, and what's appropriate. But I think it's a great question, is, how do you balance what it means to be not-for-profit with the need to have reserves and cash on hand and, to be financially sustainable, but not, or, I mean, part of what it means to be nonprofit is simply that you don't have shareholders who are entitled to be paid. So
right.
not-for-profit doesn't mean you don't actually generate profit. It has to do with, what happens with that and who you're accountable to. All right. I think maybe I will have to come back to the acts another time because it is 9:59 and I'm due upstairs in 1 minute and I think you have people.
We'll give you a break,
Right,
Thank you.
upstairs.
but no, thank you very much. This is good.
Thank you.
Yes,
And
no problem.
every time we hear this, it helps us internalize it and we make it part of what we're thinking.
Yes.
And or get more confused.
And I know you're talking to Katie tomorrow, I think, about some of the acts, the human services related acts.
Yes,
Do you want me to come in and do the rest of the healthcare related acts sometime
Yes.
next week or something?
yes, we'll do that.
Awesome. Let's see my calendar and pencil that in somewhere.
Excellent.
Thanks,
Great.
Jenna.
All right.
Thank you, Jen.
Yes, I'll see y'all
Good.
in an hour to talk about reports.
Yeah, okay. And Mike, I'm gonna ask you, how much time do you think you're gonna spend a full hour on this, or is this a?
I can spend the whole day.
I know you could.
I can spend as much
I was
time-
thinking,
You can,
maybe within this, we could take, there'll be a time for a little break. Can we do that?
Oh, nice.
And I'm wondering. And we can, well, what we'll do is as you're testifying, we might. Have a little hiatus, take a break and then come back in, to do that.
anything that many needs.
Have you met everyone?
I'm just gonna do a little, no.
Okay, so.
Maybe we just,
Right, Senator Benson and Senator Morley, and then you're,
and I'm Mike Fisher, the healthcare advocate, and I think Senator Morley and I overlapped. What years were you in that?
2004 to 2010.
Yeah, so
Yes.
yeah,
we're former house colleagues.
We are.
cool.
So thank you for having me in, and I decided to come in with a little bit more of an informal discussion, with your permission, Chair, that I think the job of taking all of this policy stuff and trying to put it in human context, and having a conversation about what it means or what you're hearing from your constituents, is what makes most sense to me. And how the changing landscape is impacting Vermonters today. Just a word or two about the Healthcare Advocates Office for the new members.
Please.
We're created in statute, funded fully from a single contract with state government, and through an RFP process and at Vermont Legal Aid since its inception, the inception in 99. Not an insurance company, not a hospital, not a state employee, but designed to be something, a watchdog, eyes and ears on this system, very complicated system on behalf of Vermonters and for you. I think, it's really clear in our statute that we're supposed to be a resource to you. And so we take that seriously and happy to talk for hours about any of the stuff you're hearing here. about healthcare. Um, and also very happy to help out with constituents. I think it's always important to say the cases that come to me through legislators are people who are often a little bit more desperate and a little bit less knowing where to turn. And so we take them seriously because you provide us connection with a set of Vermonters that often really need our help. We run a helpline. I have 8 advocates on the phone today who are responding to individual Vermonters' challenges getting through this crazy system. And we run a policy team that, and our job is to show up wherever discussions about healthcare or access to care is happening. Decisions are being made that impact Vermonters' access to care. A lot in front of the Green Mountain Care Board, a lot in this building, a lot with DEVA, DFR, and even sometimes, over at Blue Cross or over at, at private entities too.
Thank you. That's one question. Just hearing that you're an advocate for all, I'm just curious because I got a note from an individual who has some concerns about the VA and is that something that you would deal with? Because it's certainly not a state issue.
So we help Vermonters. There's no income eligibility. There's nothing about whether you're on Medicaid or Medicare or private insurance or other government insurance. We help Vermonters who are struggling with the complexity of the system, and certainly VA included. And so, just to teach
You
you,
should have a card that I could send this individual your way.
I have a permanent link in my email.
There you go.
yes. So no wrong door. We want to make this as easy as possible. This has both. This has my cell phone number on it. The middle number, I think, let's just connect me.
Thanks very much.
And just to say for everybody, the process of referring somebody to me, to us, if you ask them first, can I refer you to the healthcare advocate? And they say, yes, I just need their name, phone number, a little bit about what's going on for them, or even not. Their name and phone number, something's going on, and we'll reach out to them. Simple as that. Thank you. All right. So there are a handful of different categories of people who we think are in particular trouble today. I walked through 3 stories at the fiscal briefing a few months ago. Who was at the fiscal? Were you who?
Say that again.
You 2 were at the fiscal briefing.
Yes.
Yeah.
Legislative.
The legislative briefing.
Yeah.
I'm going to sort of base my discussion today on those same 3 stories because I think
That's
they
fine.
steer
That's
us
fine.
to these populations of people. And so the first one is about a population of people that we have, as a policy matter, allowed to go into Vermont Health Connect. They get coverage for their care in the qualified health plans, who had lower income, but were ineligible for Medicaid based on their immigration status. And so just do this, so Veronica, so these stories are based on the cases that come to us. The names, the details were changed for obvious reasons, but they're based on real people. Veronica Collins. She relocated to Rutland County from Brazil a few years ago to be closer to her daughter and care for her children. She has a green card, so she's legally residing, and now works a few hours a week doing administrative work for her daughter's business. She'll be 63 in January. And she has a chronic condition. She's dealing with a chronic condition, so she has ongoing care and medication limits. She's very low income. She's below 100% of Medicaid, of the federal poverty level. And I was wondering whether the chart on your wall is a year decline.
Well, we haven't gotten a new one yet. We're at 25.
So she's below for family of one, 15,600.
Oh, yeah, so she's below 100%.
So in 2025, she was able to buy a plan through Vermont Health Connect. And because of her income, she got a very generous cost sharing subsidy. She had no wraparound coverage for about $12 a month. And so in 2026, due to changes in HR1, her monthly cost for insurance for the same levels is about $1,300. So again, let's say her income is $10,000 a year, and she's getting a $1,300 a month charge to get the same level of coverage. Even if she steps down to a bronze plan, a lower value plan, the premiums are more than her entirety. So obviously, nothing, no options for her affordable coverage. We helped her get financial help from the hospital because she qualifies for financial assistance. One of the federal requirements for nonprofit hospitals is that they have a free care policy, and Vermont has standardized free care policies. So she benefited from that. But I want to recognize uncompensated care at hospitals, either people who don't pay their bills or people who get free care. Those costs go to the bottom line, and I'm part of that charge master. One of the factors that drive those charges. It's just to pull everything together.
What percent is that?
Good question for the hospitals.
What percent of uncompensated care is there?
Do you have that?
I don't have it at my
Yeah.
fingertips, but we keep track of it. It's something that the HCA spends a lot of time focused on, and the Green Mountain Care Board collects it in every budget year, so we can get you that number.
Spend a lot of time looking at that.
Yeah.
First paragraph.
Yeah.
Oh, yeah.
And actually it ranges depending upon what patient.
Sure. It's a little counterintuitive in counties with lower income, with more people on Medicaid, there's less uncompensated care. So it's sort of,
Yeah, it's kind of backwards.
Yeah.
What I was thinking it is.
yeah. And then let me also just recognize that low income people on Medicare, I'm going to get to the Medicare story in a while, but also are very susceptible to not being up payments. Now we'll talk about that in a minute.
One other thing that I had focused on, she's not eligible because she's not a citizen.
Mhm.
She has a green card. She's working. What was news to me during COVID is all our illegal farm workers. Their employers are taking taxes out of their wages. They are paying taxes, but we couldn't, well, I guess in the end, we covered at state expense, children and pregnant women
Mhm.
during COVID.
Mhm.
But they are paying into the system, but because they don't have a social security number, they can't get any benefits back. So
So they can't be on Medicaid then?
they can't be on
They
Medicaid.
can't be on Medicaid.
No.
So the interaction between immigration law and healthcare law is what we can come in and spend a whole day on. It's really complicated because immigration law is really complicated. There's a lot of different categories. And so I want to be careful not to make broad statements here. Yes, but is always going to be. But I did want to recognize, so there's a set of people, it would be good to get an updated number from DEVA, how many people we're talking about in this under 100% of poverty currently on Vermont Health Connect last year, no longer eligible this year. It may be 50 to 100 people. It's not a ton of people. There's another set of people who are going to lose their Medicaid on October of this year, again, because of HR 1 and their immigration status. That may be a couple of hundred people too. I guess I'm going to move on from this topic with recognition that we have taken steps. Senator Cummings just mentioned it. A few years ago, we created a program that's state-only funded for children in pregnancies, known as IHIP. And so we do have an infrastructure, if you will, to cover the costs of care. So that's a policy choice about whether there's something that could be, should be done for that population. The next population
So far, so good.
I want to talk about is premium tax credits, people who are on the exchange in the individual market who have just experienced the loss of the enhanced tax credits. So here's the worst case scenario. Oscar and Willa are self-employed in Lamoille County. Willa is an independent mental health provider and Oscar works at a local auto shop. Together, they earn about $141,000 a year, a little over 400% of the federal population. They have two children, 8 and 11, and who are doing great. Though their 11-year-old has asthma and requires daily inhaler emergency. In 2025, the family was on Vermont Health Connect MVP Gold Plan. They received a little over $2,000 a month in tax credits. This year, they got a notice that they lost their tax credits due to the end of the enhanced tax credit, premium tax credits. And so this family lost a little over $25,500 of subsidy in 26. So what are they supposed to do? So there are about 30,000 Vermonters in the individual market. I should say in 2025, there were about 30,000 Vermonters in the individual market. We don't know. It would be good to get an update at the end of open enrollment from DEVA about how this open enrollment went. There were about 6,500 Vermonters above 400% of poverty. So in this category. But almost all, many of those, of the 30,000 lost subsidy this year. So their costs went up.
Mike, question. I mean, did they talk about what that will mean for them in terms of like how they're going to live? How are they gonna, I'm assuming that $140,000 goes to pay their either mortgage or rent or, I mean, that's.
Yeah. There was over $25,000 of subsidy. No, I mean, they were sick about it. They were awake at night and are, I think. So what they decided to do.
I was just gonna say, and I've heard some pretty astronomical costs for a family.
Yeah.
Do you want to,
Yeah,
what is that bill? But they're
yeah,
not getting subsidized.
yeah, I actually don't. Well, I have it a little bit here in the story. Let me tell you what they did. They decided to go without insurance and to buy a bronze plan for their 2 kids. Kind of a typical story. We're hearing a lot of people say that they went from a gold to a bronze, they bought a lower value plan, or that they decided to buy a plan for their kids and are hoping and praying that they're okay.
Talk a little bit about the difference between gold and
A gold and
bronze.
bronze. So one of the it's sort of incredible successes that we were able to do here is in the last couple of years, no shameless self-promotion, the HCA promoted and for a number of years, and the Green Mountain Care Board ultimately did it for 25 and now for 26 is a behind the scenes pricing to be able to draw down some more federal dollars, increase people's subsidies, and actually make gold a higher value plan. That is, there's less out-of-pocket costs at the doctor's office. Gold is less expensive than silver. Sort of a miraculous thing. Higher value plan. Because it is known as silver loading, though that refers to a few different things.
Senator Beth, another
Just
question.
a quick question, and then, you know, there's an awful lot on all these different pieces, so I'm just trying to make sure I understand. I thought the children would be covered under the Dr. Dinosaur.
Yeah, so they're a little bit over 400% of poverty, and the Dr. Dinosaur cutoff is 317. So they,
Just missed, but
many Vermont children qualify for Dr. Dinosaur, but this family is above that.
Even more affluent families are having a tough time
Yeah.
meeting all of their financial obligations.
So what's really happened, right, is the federal dollars aren't coming in for these subsidies. So they're pushing the expense from the federal government onto the state government.
Exactly.
And so that's caught in this, and now we're trying to figure out ourselves how we're going to do
It's the
this.
families.
Right.
The state, so.
How much
there was-
would it be? $65 million if we're gonna cover those lost subsidies?
That's,
And we have what, $100 million more or less in a reserve fund, and we're gonna save that to pay for education.
Yeah.
And so the general fund gets depleted. In how do we continue that over time? Can't. So once you start it, becomes part of the base budget. It's a Herculean.
But the family plans, I've had families talk to me, and I've heard anywhere between $36,000 and $45,000 a year.
Mhm, mhm.
And that's, we'd be getting $25,000 in subsidy. These are returnable tax credits. You get a check if you don't owe that taxes. You're seeing a $20,000 increase.
Well, so
Expenses.
this family, uninsured for mom and dad, buying a low value kids plan for their two kids, are gonna pay about $22,000 a year in premiums for their kids. And they're above the limits for the free care that I talked about for the previous family. So this is the poster child of the kind of family, who gets a really bad diagnosis or accident and, can't pay the bills. And, again, those costs for the stabilization costs at the hospital come to all of us.
Welcome to
Yeah.
our world.
I just have to say, when we're talking about affordability, it is important to know that a lot of the affordability issues we're facing are coming from the federal government. We spent a chunk of time the other day looking at the new tax laws that will also have a negative effect on Vermont.
So, though this is also an opportunity for us to say, this loss of the enhanced tax credit hits Vermonters particularly hard compared to other states. Because we are particularly expensive. Vermont premiums are, maybe the highest in the country.
is that due to age mostly, or?
It may have some, I think it's due to many factors, I'm gonna say. It for sure has to do with our age. So again, remember, in this case, we're talking about people under 65.
Yeah.
And it may have, something to do with our rurality. It's hard to provide, much easier to provide care for 600 some thousand people in a city, than it is spread out across Vermont. But it also has to do with the prices Vermont hospitals charge. Going back to your charge master question earlier, Vermont hospitals are particularly expensive compared to their peers. And this goes to the reference-based pricing discussion you had earlier. This is our, I think, really good, timely effort to get a handle on the prices. And it's not going to be easy. It's going to be really hard. There's going to be a lot of grief about it. But we don't have a lot of those.
Yeah,
We are significantly higher, I could double on the exchange from Maine. It's a similar demographic.
Older.
They're older.
Exactly.
Well, are they? I mean, we keep switching, but
Yeah. I mean, I want to question us on two things about those comparisons. Often those comparisons are based on silver. Remember, I said Vermont has a higher cost of silver than
gold plan and so.
and then the other reason why those national comparisons are inaccurate, and I can't tell you how inaccurate, but it's just something to keep in mind. Vermont does not do age rating. Vermont is one of only two states, Vermont and New York, who don't do age rating. And because I think those national comparisons are based on the age of 40, it makes us look more expensive than we really are. I can't tell you how much.
that's interesting.
Yeah, that's interesting. But, and it might be that age rating comes up this year, some discussion of it. I'll just say an interesting discussion about whether we think it's good to shift costs from younger people to older people, at this time. There might be good policy reasons to do that. I have always cut my head a little bit at.
Well,
there's
The
certain-
administration has a provision in the bill that they've introduced. I don't think we've gotten it yet. I know it's introduced in the House that has a age-related community ratings piece, and that gets to the age.
Yeah.
You talked about.
Love to talk more about it.
We will.
I have one more story, and I think, maybe 10 minutes or 15 minutes, we can,
Cool. Yeah.
depending on questions. So the last category, I don't know what, I don't have a story about the small group, and I think I'm remiss about that. I think it's important. So everything I've been talking about for insurance has been for small employers under 100. Employers, I'm sorry, I've been people who don't have employer-sponsored insurance, who don't have no offer of insurance. There is also the small group that is people who do have an offer of employer-sponsored insurance, but there's employers under 100. And so they're in a different market and they are rated differently. Most all the rules are the same about, or the rules are the same about what's covered. The plan designs are the same, but they're rated separately. The small group's in trouble. The rates in the small group have been growing at an unsustainable rate, and those guys have no subsidies available to them. And
What do you mean by small group? Sorry.
so they say again, small employers under 100. So what's the difference between someone in the individual group and the small group? The individual group has no offer of employer-sponsored insurance, and the small group person does have an offer of employer-sponsored insurance. They might both work for a company with 10 people.
But they're using Blue Cross Blue Shield or Aetna or whatever.
Blue Cross Blue Shield or NDP are the two
Okay.
carriers in that market. I have been afraid for some time that we've been seeing adverse selection, that is a sorting of the small group into healthier small groups, healthier people moving to self-funded, and sicker staying in the public marketplace. And that just drives up the rate even more when the average cost, when the average life is more expensive to drive. I just say that it's something that I've been writing about for years and years. I think we see it happening before our eyes. It's a politically probably impossible thing for you to do anything about or recognize. I would call for a straight up prohibition on stop loss insurance for very small employers. But I would get very little support from the business community and from
I'll be my.
and
You were explaining that, right? Sorry.
I realize that I'm so
You
hard.
just stepped into finance.
It's just
We won't even talk
Sure.
about associations.
Thank you. And so this is a conversation that will happen down the hall, but,
Okay. I'll
but,
be there.
You'll get it.
I think we see active sorting of the population into healthier people going into into the individual market. I'm sorry, into the self.
Active
Yes.
sorting.
People who are quite ill or have
Well, so
significant illness in
in
the
this case,
family.
you're a small employer, you're
Yeah.
trying to figure out how to cover your employees, and you shop. And you go to a third-party administrator who does self-funded plans, and they give you a better rate. Because the age of your employees is healthy, so the factors of your employees. Or they give you a worse rate, or don't offer you a rate at all, and you're stuck in the queue. So that's actively happening. But small groups in trouble. I really want to recognize that. Small groups in trouble, and I think my job is to advocate for Vermonters' access to care. I don't necessarily care more about the individual group than the small group. Both of them are.
Everybody's in trouble.
Yeah.
And we know that.
Yeah.
It's top to bottom,
Yeah.
age wise,
Yeah.
and bottom to top, but
And we could try to balance that with, are those groups joined? Are they separated?
and we have limited control. We don't regulate ESI, and so we try to look for some volunteer support in building our risk pools. And
We do regulate stop loss insurance,
yes,
and nobody buys self-funded plan without getting stop loss insurance. And so that's the hook. Okay, Medicare appointments. So Betty and Hal. Betty worked as town clerk for 27 years. And Hal worked as a contractor doing carpentry in the winter and landscaping in the summer in Bennington County. They raised 3 kids, were growing up and doing great. And they have 2 grandchildren who live nearby. Betty is 71 and Hal is 73. Between them, their social security checks give them an income of $46,500. That's approximately 215% of the federal poverty. That's nothing to sneeze at. That's a decent amount of money, for a couple. But as they transitioned from 25 to 26, they freaked out. They had a very hard transition, prohibitively hard transition, and I'll explain why. No surprise, they spend their money on their mortgage, their taxes, their groceries, and their healthcare. Betty's healthy, but Hal manages a chronic condition that requires medication and appointments with specialists. So in December, they learned that their Medicare Part C plan ended. And so they started to shop for coverage for 2026. They make too much money to qualify for Vermont's Medicare Savings Program.
400% of poverty.
So Vermont's Medicare Savings
What
Program
is it?
currently caps out at 202% of the federal poverty level. And so let me just say this again. This family earns $3,800 a month And the cap on MSP, Medicare Savings Program, is $3,600 a month, so they're just above.
Like, it's very expensive. I don't want to pry, but I mean, you don't know if they have savings and things like that, right? This is just,
It's true, this is based on their income,
okay.
and their income is all fixed, it's social security. So when people talk about their income, people often think, oh, there's things you can do with your income to make yourself qualify for something. Not so in this world. You get what you get and it's fixed.
And the number, Beth Pierce did a study when she was treasurer, and the number of Vermonters that have no retirement savings was staggering. Which is one reason we started the state, and I'm forgetting the name, but if your employer's willing, the state, you can contribute a couple dollars a month and your employer can contribute.
Yeah.
And the state will manage your IRA, essentially, you can set up an IRA. But it came out, the number 80% sticks in my head, but I have no idea if that's correct. But it was staggering to think that you are dependent on living on Social Security.
So between them, their cost for their Medicare Part B premiums and their Part D premiums for drugs, and the cost of a Medigap plan, they're looking at premiums of about $16,500 a year, or 35% of their fixed income. If we try to count, that's not even counting their out-of-pocket costs. I want to remind you that Medicare has no cap on out-of-pocket costs, no annual or lifetime cap. So it's generally Part A, Part B, hospitals and outpatient parts of Medicare pay that's generally 80% of the costs, 20% of a hospital stay. It's too much. So they decided that they couldn't afford a Medigap plan. So they went without secondary coverage.
For Part D, we're talking.
No, we're talking about the private plan that people buy to cover that 20% cost sharing.
Oh, so we're talking about. the
Medigap or
Right. The
supplemental
whole thing,
Medicare.
yes. Maybe.
Everything in Medicare has at least two names, just to keep it confused. So they lost their guaranteed issue. In Vermont, you have generally a 6-month period for where you can buy a Medigap or Medicare supplemental plan and get guaranteed issue. That is, the plans have to offer it to you, and they don't charge you extra because based on your health status, medical underwriting. So they lost that, they had no choice. This family can get financial assistance from the hospital. So they can get some help there for their Part A and B cost sharing. And Vermont also does have a prescription drug program called V-Farm, still exists today, which they also qualified for.
What's the FPL on G Farm?
I'm going from
I know.
memory, I think it's 100.
Yeah, it's not high.
I'm not gonna say it because I can't remember. I don't have it.
No, don't worry about
I
it.
don't have that
It's
cheat
okay.
sheet in front of me. Don't you have my cheat sheet up there somewhere?
No. We need to.
I always have that cheat sheet.
Oh, I gotta have it in my drawer, but,
We have it somewhere.
yeah. Can I ask a question while
Yeah.
I'm looking? It's the green sheet, right? 'Cause
Yeah, it's
Green or blue.
Yeah, when you say that the hospital is able to help them, is that their local, can you explain that?
One of the only things in the.
I deliberately left that in your drawer.
Between us, we're gonna figure this out. So V-Farm 3 goes up to 225%.
Okay, 225.
Yeah, there's like, I do want to remember, there's like 4 or 5 V farms right there.
just
Three, okay.
and they cover the exact same thing, but they have different premiums.
So sorry to get in the weeds, but when you say the hospital is able to help them, is that their local hospital and how is it able to help them? I don't.
Yes.
So the hospital is the free care policy at their
Okay, that's okay,
the
got it.
Vermont Hospital They Get Care
Okay,
Act
got it, thank you.
would be able to help them at this income.
Okay.
Same statement I made earlier.
Right.
This is a great safety net for many Vermonters to have a free care policy. Would very much support it. Now the costs go to the bottom line of the hospital. So this last family is an area where the legislature has done a great job in recent years of expanding the safety net, and it wouldn't be a testimony from the healthcare advocate if I didn't at least say, hey, we could go further. It's incredibly inexpensive for the value.
So we cover, as I recall, in one of these things, Joe and I get briefed on, we cover a lot of add-ons in the Medicaid side of things, correct?
Yes, yes,
There's the basic,
yes.
and then,
Medicaid.
which is majority of the cost, you
Right.
said, no one said we're in there.
Yeah.
And then it didn't cost a lot to do the add-ons, am I saying that?
Yeah,
Medicare.
I might
Medicaid,
Medicaid, we can do add-ons.
I might say it just a little bit differently.
Yeah.
People talk about Medicaid as if it's a program. It is a incredibly complex set of programs that serve different populations in different ways and with different rules. And so generally it is broken into two major groups, one for, well, I should say three, one for children that we dub Dr. Dinosaur, and one for people under 65, adults under 65, and one for adults over 65. There's much, much more than that, but those are sort of major components. And the Medicare savings program I'm talking about is even sort of a complexity of the over 65 program, but it requires very little state dollars to draw down significant federal dollars.
Yeah, we got some significant 80-20 matches. We get 50-50 matches depending on programs we did.
it's in here.
Yeah, you got it.
And in this case, it's not even the match rate. It opens up eligibility for programs that are 100% federally covered. And so, love to come talk to you more at a better date. There's very little good news on the landscape. The incredible change, the positive change that went into effect just this past January 1st, just a few days ago, that you guys accomplished for MSP is sort of miraculously good news for a set of about 14,000 Vermonters who are gaining ground, are able to cover their healthcare costs in a reasonable way.
We have AHS coming in on the federal update. And then it would be good to have you come back in and sort of underpin that as well. I mean, because it's
Yes.
Yeah.
Thank you. Always happy to answer questions.
Good.
I think we're gonna take a break, are we gonna take a break?
We are about this.
I think one of the overarching things I'm hearing from the folks like Mike is, what that concerns me is more and more people are gonna become uninsured, potentially, right? I'm guessing. And
Can I say uninsured or underinsured?
correct, both,
Mhm.
both.
Mhm.
And then we're trying to make the hospitals be more efficient, effective,
Mhm.
correct?
That'll take the money that we have in the system and move it somewhere else.
Well, I'm concerned because these individuals are gonna be going to the hospital, in my mind.
Yeah,
And that's where you're gonna see
Yeah.
the cost drivers come up at the hospital level too, I would think. Chair, maybe I'm wrong. I
Well,
don't
it
know.
will, so, you know, predicting the future this is one of the things we have to be careful about.
Okay.
What we need to know is the data about what does it look like for the numbers that are coming up, more underinsured and uninsured. Right now, the hospitals are also looking at that. AHS is looking at that. Healthcare Advocate is looking at, so we need to bring all of that information in here. And then say, okay, right, how far can the Green Mountain Care Board go in its regulation, or DFR go in its regulation of rates overall, to make sure that we maintain the solvency, insurance companies, financial sustainability at the hospitals, and people have access. So yes,
I'm just concerned.
you know, you should be concerned.
I'm very concerned. I think you ultimately it's gonna be less services.
It's what?
There could potentially be less services. Is one of the.
That's one of the things that we hear. We're in for, when we hear from DEVA, and we hear from the Department of Vermont Health Access, and we hear about what's gonna be slashed and burned at Medicaid,
Mhm.
it's scary. And what's gonna happen to the people who need it the most? Totally scary.
Yeah.
And the other thing that we don't deal with in here, we deal with down there, that I'm concerned about. It's like that couple that bought bronze plants for their kids. Pretty likely that younger, healthier people may look at that bill and say, I'm just gonna put my money in the bank
Right. They're not gonna do
and
that.
roll the dice and hope I don't. And if I had one guy call up and say, oh, my grandson smashed up his motorcycle and he got all the care he needed. He didn't have any insurance. I said, no, I paid for it.
Yeah, somebody
as-
pays for it.
as-
Everybody
Yeah.
wants free.
As we take those younger Vermonters out of the insurance pool, I've got a bill on my wall that says we should let people up to 26 stay on Dr. Dinosaur. If I take those younger, healthier people out of the insurance pool and leave more older, yeah, it goes up. We need those younger people in that pool because we do community rating. We don't do age rating. When we did, my son went to Europe. It cost him $300 for a 6-month comprehensive plan. Life was good. He was 21 years old. Once he's working, he needs the, because he's on the campus.
I think your assessment and your recognition of how tricky this is correct. I mean, I would say the way I've been thinking about it is this sort of financing question. How fast can we reasonably ask hospitals and providers to cost less without destroying them? And how fast do we have to ask them to cost less so that Vermonters can afford the care? There's the conflict in my mind, and that's sort of the concept of transformation. What do we have to have in rural communities? What services do we have to have within so many miles? What should we not be doing spread out all over the state? We may be only doing a few centers of excellence. That kind of planning and organizing is, I think, necessary. And my fear is that if we don't do that kind of planning and organizing, the market is going to do it to us.
The market's already done it to us, hasn't it?
Sloppy, horrible way that will just close hospitals.
But we are doing that planning, right?
We're doing it. We're starting. That's why we have 167 and 51 and 68.
From the healthcare advocate perspective, I think maybe it's part of my job to be impatient.
You're impatient.
Is to say,
Never would have expected.
I wish we were further along. It
Okay.
Really,
I wish we were further along too.
That's good.
And it's what I talk about.
Yeah.
You can't turn the Titanic
Undoubtedly.
that way. And and you know what? What we did was we got everybody on board. Now everybody's on board.
Yeah.
Now they can start to row over to the.
But they're gonna have.
It's a rowing, it's not.
but
Pay all prices.
the market is happening,
Yeah.
you know, okay, we made it through this year. How's next year gonna go? What kind of a rate increase are we gonna give insurance companies? and hospitals?
But Mike, think of this. July 1st put a huge cavity in the work we're doing.
Yeah.
And now, do we knee-jerk reaction and upset throw the baby out with the bathwater? That's a concern. We can't do that. Well, we can push it up a little bit, go a little bit faster. And I agree with you. We have to move faster, and that's why we have HROC, and that's why we have this work. That's why we have you to keep us honest about going faster. You gotta do it.
The they that you are all referring to, because Ann just said it too, and Senator Cummings, they need to move faster, the hospitals need to move faster, let's just name.
Planning
the they.
process, the advisory committee, the AHS, the Green Mountain Care Board, the hospitals, us, the primary care, all of
It's so hard because there's so many of them.
They are so.
So it's just,
And we have
it's so slow. It's gonna go slow.
14 or 15, we found the retreat, independent, with their own private boards, making decisions, and how do we make this into a system? It's a big task, and good people are working on it. I don't mean to slight them. I just mean to recognize, I see the clock and I see the, I see the regulatory process churning around again, and its impact, and it's sort of expected.
So here's a concern that I might have. We put millions of dollars into this process. I don't want it all going to consultants coming back a year later. I want it going right into the infrastructure changes and going on. So that's a question we're gonna ask when we have folks.
And maybe I'll just, one more thing as I part, I just want to say, everything we're talking about, the urgency of this problem
Yeah,
isn't mitigated, isn't reduced one bit by this huge boatload of money, which is said to be coming to rural health.
Thank you for saying that.
That money can be very useful, it can really help us, it can help us with some of this task, coordinating care between hospitals, for instance. I'm hopeful about it. But even though it's 5 years, it's still one time.
And it's
So
not,
I didn't know that. It's one time for over a period of 5 years.
Yeah.
So we gotta be careful.
We can't use it we're not allowed to use it for provision of care anyway, but we can't come to depend on
we
it.
we have AHS coming in to talk about RHT, Rural Health Transformation Grant next Wednesday. And we'll also have others in to talk about it and what it means. It is aside and separate. And I thank you, Mike, for saying that, because it is aside and separate. However, it has an effect, and we would not want the public to interpret this as the godsend. It is,
Yeah.
it is against it. We'll find out what it is. I'm not gonna talk about what it is.
has the potential to lower costs in the long term.
We'll find out.
Correct?
Potential, find out. Save it for AHS.
Thank you. I love spending time with you.
Well, this has been good conversation all around, and I thank you, and